We've heard a lot about out-of-pocket costs that consumers bear in relationship to their Social Security benefits. It's kind of interesting to me because last year we heard that Part D was less costly than had been anticipated, and if you actually looked at premiums and you looked at out-of-pocket costs for beneficiaries, that wouldn't be true. What interests me about this slide is the increasing costs for out-of-pocket expenses and the fact that research indicates that Medicare beneficiaries don't choose the plan that is least expensive to them. There's a report done recently by Jonathan Gruber from MIT for Kaiser, which says that beneficiaries just don't choose the lowest cost plans, and part of the reason is that they find the Part D program too complicated in order for them to do the analysis. And so that leads me to one of the recommendations that Brian mentioned. In addition to simplifying the Part C plans, the Medicare Advantage plans, we need to simplify the Part D plans. There are too many of them. The benefit packages vary too much, and it's really impossible to make any choice. There have been some kind of recommendations that we have standardized benefit packages, and perhaps that we use a model similar to the Medigap model, where NAIC developed standardized plans, and that way you would know when you have a basic plan that the basic plan is going to be the same, and you'd be looking at a company based on its formulary and its quality, rather than trying to decide what's going to work the best for you. Part B costs and Part D costs are going to be growing steadily over the next decade. What's interesting about this slide is that it only looks at premiums and deductibles. In the Part D context, it does not include drugs that are not covered by the plan, and sometimes those are drugs that are not covered by Part D, or they're just drugs that aren't on the formulary. It doesn't include drugs where people don't go through the appeals process because it's too complicated. They don't know that there's an appeals process, and they'll say, I'm going to pay out of pocket because I don't know what to do next, or even worse, they'll say, leave the drug at the pharmacy. And it does not include any of the cost sharing that Marilyn has talked about. Total premium increases of over 200% have been tolerated since 2006. We look at Humana, United Health Group, and WellPoint because they have among the largest share of Part D enrollment, and their premiums have increased substantially. According to Kaiser, 90% of enrollees faced premium increases between 2008 and 2009 if they did not change plans. And we know, again, that beneficiaries do not change plans. In 2006, there were 2.4 million enrollees who changed plans, but of those, 1.1 were people eligible for the low-income subsidy who were reassigned to another plan. In 2007, there were 3.1 million who switched plans, and two-thirds of those, 2.1 million, were low-income subsidy individuals. So again, even though premiums increase, even though out-of-pocket costs increase, Medicare beneficiaries don't exercise the choice that they're supposed to. They don't do the analysis to try and find the cheaper plan, and it's because, again, the system is too complicated. We hear all the time from people who say, I went through that once, either for myself, my mother, my neighbor, and I never want to go through that again. One of the biggest issues and the biggest complaints we hear is about the donut hole, that wonderful gap in coverage where people are paying for the full amount of their premium, but they're not getting any prescription drug coverage at all. More than 3 million beneficiaries are at risk of falling into the coverage gap this year. It's important to note there are no prescription drug plans that offer any kind of coverage in the coverage gap. In 2006, there was one plan that offered some coverage in the donut hole. It quickly discovered that it was too costly to offer coverage. So they dropped that coverage in 2007. In 2007, there was another plan, a different plan, that offered coverage in the donut hole. They also discovered it was too costly. You can get some coverage if you go into a Medicare Advantage plan, and the reason that Medicare Advantage plans are able to provide some coverage in the donut hole is because they are overpaid, so they use some of their overpayment to fill in the gap. What happens to beneficiaries when they are in the donut hole? Well, research shows that they do not take their medicine. And there's some statistics that show that in 2007, 64% of all beneficiaries who reached of Alzheimer's patients reached the gap. 51% of people who take oral medicines for diabetes, and 45% of people who take antidepressants. So these are people who are taking medicines for common chronic conditions. Many of those individuals have multiple chronic conditions, and that's putting them into the donut hole as well. Can we close the donut hole? Yes, we can. It would cost $134 billion over 10 years, according to CBO. If you changed the way that drug prices were calculated, if you applied Medicaid-like rebates, you could raise $110 billion of that money. The donut hole can be closed gradually, either by being phased down. You could increase the initial coverage limit. You could decrease the catastrophic level. You could phase it in. You could slow down how it's indexed by not indexing the donut hole to the consumer price, by indexing the donut hole to the consumer price index rather than to the growth in the cost of drug spending. The other thing that we want to point out, of course, is that Part D, as Marilyn indicated, is not a generous benefit. Like the rest of Medicare, it is not as generous as even FEHB or your typical large employer plan. One way that we can close the the donut hole is to improve the low-income subsidy. If we make more people eligible for the low-income subsidy, then more people will not face the coverage gap and they'll be able to get the drugs they need throughout the entire year. If you look at this chart of who is getting the low-income subsidy, there are still 2.3 million individuals who are eligible but not receiving the subsidy. This can be addressed by, of course, additional outreach and by improving the way eligibility is determined. But it's also interesting to note that more than half of the people who currently receive the low-income subsidy receive it because they were automatically deemed eligible for the subsidy, even because they're full benefit dual eligibles getting Medicare and Medicaid, they get SSI, or they have one of the Medicare savings programs, Quimby, SlimB, or QI. There were efforts to improve the low-income subsidy in the MIPA legislation that was passed last year, and we're grateful for that, but more can be done. And one of the issues that needs to be addressed is the instability of the benchmark plans.